Hi, like he said, my name's Bridget Ollesch, and I was the Bowen Fellow in Children's Research. So I was working at the Children's Hospital Colorado. It's located in Aurora, and it's a really top-notch hospital. They have over 2,000 specialties, and they're one of the only dedicated level 1 trauma centers in the entire region. They're responsible for almost all of the research that's published in the Rocky Mountain region, and they also have the Center for Gait and Movement Analysis. That's a picture on the right. It's a big fancy room with lots of technology where they analyze how you walk and for different gait abnormalities, and they determine treatment based on that. That's pretty impressive because it's the only one in the region, and it's one of only 40 in the entire country, and I got to check that out while I was there. So the project that I was working on was related to discovering outcomes and complications after spinal fusion in patients who have myelomeningocele. It's a big mouthful, but basically it's a very severe form of spina bifida. So these patients that have spina bifida, it's very, very common for them to also have spinal deformities. And two of those are scoliosis and kyphosis. So scoliosis is the typical like S-shaped curve. Hopefully you can see the x-ray. And it's much more common than kyphosis in this patient population. In fact, almost all patients with this form of spina bifida develop scoliosis. So the scoliosis can be very severe, and it causes a lot of problems. It can prevent them from walking, so a lot of these patients are wheelchair bound. It interferes with just basic daily functions. So one of the biggest things is it affects pelvic obliquity and your sitting balance. So it's hard to see, but you can kind of see the top of the hip bones. Pelvic obliquity basically refers to your hips are kind of like this. But imagine if you're sitting in a wheelchair all the time and your hips are like this, it gets really painful and you can form a lot of sores from sitting like that. And if the curves get severe enough, it can actually prevent respiratory function. So kyphosis, it's a lot less common than scoliosis. Kyphosis you can think of as typically like the hunchback type of deal, but it can also happen in the lumbar region, so your lower back. So kyphosis appears at a very young age, and it's pretty progressive, so it usually requires surgery. And again, this also affects the sitting balance, the pelvic obliquity, and you can get skin breakdown over that hump, which can become infected, which can be a big problem. So again, it can affect your eating and breathing, and also just it can interfere with daily functions. So the goals of treatment are typically these patients undergo spinal fusions, and basically that's a type of surgery that it removes the joints from your spine and then basically straightens it out, and they usually have to put hardware in and they fuse the vertebrae together. So one thing is, you want to get a solid fusion. Sometimes you don't get a solid fusion and you can get like a false joint. And you also want to get a level pelvis to increase sitting tolerance. However, the issue is that particularly in this patient population, the rate of complication is very, very high. And usually that refers to infection. This isn't your normal type of infection. This is deep infection that requires you to go into the hospital and have that wound opened up and irrigated after surgery. Again, this is more specific to this patient population. A lot of people have spinal fusions that don't have spina bifida, and those usually have no problem. So our goal was to try and find out why. So we wanted to first off identify the incidence of major complication. Again, we were specifically looking for a deep infection. So we wanted to find out how often that was occurring. We were also trying to see if we could describe factors that would predict complications or infection. And we also, just from the perspective of the providers and also from the patients, we were trying to determine if the benefits of this surgery outweigh the risks in this patient population. So going into it, we hypothesized that the rate of complication would be very high, and we also thought that there would be certain factors, different variables that would contribute to the high rate of complications in this patient population. So my job was to go through old patient charts. So surgeons keep very detailed notes when they do surgeries. They record everything from the beginning to the end. And my job was to go into those patient records and basically collect information that could possibly predict complication. How long was the surgery? Did they have blood transfused? How much? So different things like that, you know, how long were they in the hospital? How long were they in the ICU? This was my favorite part, actually. So another part is I actually did radiographic review. I would look at x-rays and I learned how to measure those x-rays, and we would compare the curve of the spine before surgery and after surgery. And so we were looking at percent correction of the curve in both pelvic obliquity, and we tried to find x-rays for 1 month after surgery and most recent. So the surveys, this was actually, again, I really liked doing this. I really like doing everything, but this part was really fun because I got to help build up the survey. So I got to think of questions and format them differently. So the surveys were a lot of quality of life stuff, and this was to help us determine if the benefits of surgery outweighed the risks from the view of the patient as opposed to the view of the provider. So our results, I was actually pretty lucky. We did get to do some preliminary statistics. We did not find anything, there was nothing significantly related to incidence of complication. However, we did see significant improvement in both spinal curvature and pelvic obliquity at all time points. And another thing that I wanted to mention too is we also noticed that the rate of infection at Children's Hospital Colorado was reported much lower than what's usually reported in the literature. So just kind of speaks to how awesome the hospital is. So again, this is the results. This was one of my favorite parts. You can see, it's kind of hard to see, but you can see the really S-shaped curve. This is one of the x-rays that I measured. That's before surgery. And that line that's slanted, that's measuring the pelvic obliquity. And so afterwards, you can see all that stuff in there. That's the hardware that they put in. And you can follow, the spine is almost completely straight. So we saw corrections of that kind across all time points for most patients. So it was pretty impressive. And I personally really enjoyed learning how to measure these x-rays. It's not something that people typically learn to do. So that was really exciting. So since we didn't find anything that was significant towards these in rates of infection and complications, we tried to look at, you know, how can we expand the study or fix the study to try and find what might be affecting or inducing complications. So we talked about moving towards the possibility of moving towards a multi-institutional review. So myelomeningocele is actually pretty rare, and so the patient population was fairly small. So it's hard to get really good data from a small patient population like that. So the other thing is I started sending the patient surveys to patients about the beginning of the summer, and I did a 10-week internship. And a lot of them hadn't responded yet to those surveys, so we didn't have all that information collected. So that's the other thing. We never got to really analyze or look at the data from the surveys quite yet. This was a great learning experience for me. That was actually one of the models that Dr. Georgopoulos, she was my mentor, she used that model to help me see what she was talking about when she was talking about spinal fusions and the different lumbar vertebrae versus thoracic, all that stuff. I learned about the process of research, so I learned a little bit about the Institutional Review Board. That's in Colorado, it's called COMRB. And so I learned about what's okay and what's not okay. It's very different when you're studying people than if you're studying cells or animals. I also got to learn how to navigate EPIC, which is where most of the medical records were located. I'm interested in pursuing going to medical school. So learning how to navigate that is going to definitely be beneficial to a career in healthcare. REDCap was where we stored most of our data, and I learned how to utilize that, which is something that's going to be useful for future research opportunities. A professional work environment. I was actually pretty lucky, well, depends on how you, I thought it was lucky. My project was pretty independent for the most part. I'll give you just an example. The people working on the project included myself, my mentor, Dr. Georgopoulos, a research assistant who was gone for the whole summer, and then there's kind of an overseeing research assistant who helps with everybody's project. So for the most part, I was doing pretty much most of the project and the data collection. I did meet with my mentor maybe like twice a week. So a lot of it was pretty independent, which was scary at first, but it actually taught me a lot, and I feel a lot more confident. I also had the chance to go to different lectures that were put on by the medical school that's right next to the Children's Hospital. And I discovered I have a real interest in pediatrics. I already know that I'm interested in healthcare and that I would like to go to medical school, but being at the Children's Hospital just made me realize I really love it. So that's something I'm going to keep in mind for the future. Job shadowing, that was really fun. I got to go watch a surgery. It was really cool. I got to watch a spinal fusion, and I felt like that helped me understand my research a lot more. One of my favorite days was in the morning I watched a spinal fusion, but then they broke for lunch, and then in the afternoon they'd had somebody who had hardware in from a spinal fusion, but it had got infected, so they had to remove the hardware. Well, I mean, it was unfortunate for them, but for me, I got to see what the spine looks like once it's been fused together, and it was really neat to see the before and after in one day. That's pretty rare. I also got to shadow in departments outside of orthopedics. Orthopedics is still one of my favorites, though. So, mentorship. This is Dr. Georgopoulos I got to work with. She's been super great. I was looking for different research opportunities this summer, and I applied to a few because I wasn't sure what I wanted to do. And she was kind enough to write me a letter of recommendation for a different research opportunity, which I was accepted for. I denied that research opportunity, however, because I was accepted to go back to the Children's Hospital. So I'm very excited. I'll be working with her again, and I'll get to finish the project that I was working on before, and then I'll also get to help with a new project. Something else that I really liked about working with her is orthopedic surgery right now is it's a very male-dominated area of medicine, so it was pretty awesome that I got to work with a female doctor. So I want to give a big thank you to Dr. Georgopoulos, who is the principal investigator, or my mentor. One of the research assistants there is Patrick Carey. He's actually a Cornell alum, and he was super helpful and everything, and he's been a contact of mine as I've applied to go back to the Children's Hospital. My faculty sponsor, Craig Tepper, the CEC staff, Jason and RJ and Megan, who's not here anymore, but all of them helped me at some point. And lastly, I want to thank my donor, Jesse Bowen, who is a former Cornell trustee.